I'm sorry about that. I have to say sorry for Knut Beitzel again. This guy fell sick and had a tooth operation yesterday, so I'm gonna try to wrap this together. And this was my original topic, and I put some slides in for the acute setting as well, so that we can discuss all this together.
Okay, thank you.
Well, this is what we all know. This is the restraints of the AC joint. We know important, especially for the vertical instability, that's the CC ligaments, and then we have for the horizontal stability, especially the AC joint capsule. In many times, patients will come in your office and they have already some pictures. They come from skiing and they say, "Doctor, what's this?" They told me to go and see you. This is not even a weighted radiograph, but you can already see there is something wrong. This line from the acromion to the clavicle is interrupted here, and also in the normal, this is not an Alexander view, this is a normal outlet view, you can see there is something wrong. This is a severe AC joint dislocation. So let's go into detail. How does it happen? Etiology of this. 70% of all injuries during sports are related to the AC joint. Most of the times, you can see directly here. This is Mo Salah, this is Sergio Ramos, and what this guy did wasn't nice, and he fell directly, a direct blow to the shoulder, you can see it here, and this guy is a good team doctor, I think it's a physiotherapist, he already is touching the AC joint and knows exactly what happened. This guy had a AC joint disruption right away, and he didn't play this game anymore. You all know the Rockwood classification, this is why I'm not going to go through this in detail. But now this is important, when are we going to do surgery? This is what the literature says, and this is what's going to be discussed all the time, and we can discuss later on. 1 and 2, you stay conservative. Most of the times that works. Type 2, you look at your patient and you talk to him. Type 4 and 5, and if you see a 6, most of the colleagues would say that these patients should undergo surgery. If we are close to doing a surgery, what are our options? This changed tremendously with this paper from Eugene Wolf in 2001. Before, we already had 100 and over 100 different techniques. Now these techniques developed, evolved in a completely different direction. We realized that we could also do the AC joint stabilization arthroscopically. This is how we did it, how we started it like years ago in Munich. We did a double tightrope technique to restore both of the CC ligaments separately. This is what we added some years later, an AC joint cerclage to address the horizontal stability. We're going to talk about this later, but this is widely used today. I'm going to show you the arthroscopic technique that we are doing now. You see the preparation of the subcoracoid space. You have this one drill hole. We're only using one drill hole. You can measure medial lateral that you're in the center, and this is very important with your drill. Then you have this passing wire. Bring in your sutures for the small dog bone implant. Now we're already subacromial. Do 2 drill holes from craniocaudally and bring the same tapes over the AC joint so that you have an AC cerclage at the same time as you do a CC. So this is a combination of arthroscopic AC and CC joint technique. We just published it in Arthroscopic Techniques if you want to read this again. What are the clinical results? They're quite good if we look at this. This clinical results, 58 months findings. They say it's good to excellent in this paper. 23 patients, subjective satisfaction almost 100%. So this is quite good. We looked at sports and return to sports, and we could say that there was no significant change in activity levels or participation in overhead and even contact sports. I think this is quite good for these new techniques, and we are really satisfied with this. So, goals achieved in 2019, everything is fine? No, of course not. It's the AC joint. There is never everything fine. You can see what can happen, things can break out. And if you look at the problems, and we did it in a study as well, like Matthew Milewski did, this is what can happen even today. 90% show a loss of reduction, 10% recurrent instabilities, 40% persisting horizontal instability, up to 20% fractures of the coracoid or the clavicle, and up to 20% pain related to the implants. Infection is a really little problem. Let's go through this. Loss of reduction, you can see it here. This is not normal anymore. You can see what happened. You have a tunnel widening here. Sometimes you have a bony migration of the implant into the bone, and this reduces stability, and if it's not healed, it's going to be a little bit more unstable. What is to do? Is it clinically relevant? And we can be happy that in most of the cases, this is not correlating to the clinical outcome. So, do we have to do anything? In most of the cases, not. If this patient has really ongoing or recurrent pain, you might have to go in and treat it like a chronic case, as we have to talk about later. How can we prevent it? As you see here, nowadays we use larger buttons that are not migrating into the bone. We are using strong suture material. In former times we used the PDS cord, which was too elongable. This is not the case with this here. And of course you have to address both directions. Maybe that was the fault in former times. We only did the CC stabilization and didn't care at all about the horizontal stability. Painful recurrent instability. So it's really dislocated again. As you can see here, there is one implant torn out of the coracoid process. It can be a loosening of the sutures that you knot, or it can be a cutout of the implants. Is it clinically relevant? Yes, it is, because good to excellent outcomes are only reported in patients without complications, and this is a complication. So what should we do with these patients? If they have problems, this is the main point, if they have problems, you have to go in and do a revision surgery. In these cases, then you have to put a graft, and I'll show you later how this works. Now we come to this point, persistent horizontal instability. You can see this guy had a hook plate in, they put it out, and it's unstable in both directions again. If you look at the work from Markus Scheibel, he showed that up to 40% of the patients show this persistent horizontal instability after a CC augmentation. And this is what we could show, this is what we could show in our biomechanical study in Munich by Tim Sire, that if you do not address the AC joints separately, you will not be able to reach the native stability, especially for the horizontal plane. So this is important. This is what we didn't look at the last 10 years. A new study from Felix Dörner from Munich as well. He looked biomechanically at different choices for these cerclage materials. Not the material, but the technique. Where do you go in? How do you do a triangle? Do you do a box? Do you do a figure of 8? And he figured out it all brings it almost back to normal, to native, and it no matter what kind of technique you use. There was no significant difference. This is an HGSM. What I showed you before is a kind of this technique. Okay, you go, take the sutures you have here, bring it through the acromion, up and down, go back and knot it together. Let's talk a little bit more about the fractures of the clavicle and the coracoid. This is what you can estimate here. Here you can see the clavicle fracture. Of course, these are problems then you have to treat. Most of the cases in literature, the coracoid process fractures heal by itself without you doing anything. But of course, displayed fractures need some surgery. This is what Uli Spiegel did. He could show that, of course, if you have smaller drill holes within the clavicle, it's better for the clavicle. And if you put 2 6-millimeter drill holes right next to each other, tenodesis screws in it, the fracture risk is much higher. The same we could show for the coracoid process. It's much better if you only use 1 2.4 millimeter drill hole and not like we used to do it before, 2 4-millimeter drill holes. That's what the study looked like. How can we prevent it? I think this is clear. Use the smaller drill holes. It is important to visualize the coracoid process from the subcoracoid space, that you see exactly where your drill hole is coming out. And if you are wrong, don't just pull in your implant. This is important. If you already have a revision, this last point is important too. Don't make a Swiss cheese out of your coracoid process. Leave it, and I tend to wrap around the graft around the coracoid and around the clavicle. So don't put some more drill holes and more until you think this is fine, and then you have 5 drill holes in the coracoid process that's going to break anyway. So let's move on to the chronic instability. You have seen this already. This guy didn't have surgery before, but said, like, after 3 to 4 months, he said, I'm not feeling well, and you can see what happens. This is the clavicle, and by doing the adduction test, it shifts completely over the acromion. So this is a case of a dynamic, horizontal, and vertical instability. The question is, what are we going to do now? What to do for the failed conservative, this is the chronic cases, not the revision cases treatment. They have ongoing painful instability, so you have to do something. They say it's not going to work like this. I can't do my sports. I can't do my overhead work. This is what you hear. What does it mean chronic? We have to discuss this. Do we always need a graft? Is it a dogma? Do we know this? What are the possible techniques that we can use? And what can we predict for the patients? So if you look at the surgical techniques, this is the acute sector, this is the chronic sector, and it's almost the same. You can choose among probably 150 different techniques. And if anyone could stand up and say, this is the golden grail, this is how you should do it, you should please stand up. We don't exactly know what is best to do. We're getting better, this is what I think, but we don't exactly know. There is no golden standard. And I think in this room, everyone who's treating chronic AC joint instabilities is doing it slightly different. I'm sure about that. Is there a consensus about graft? Do we need a graft? Biologic augmentation is supported by retrospective clinical studies. There is little good evidence with or without graft, and there is only this one study by Fauci et al., and they showed on 40 patients that the biological augmentation in 40 chronic cases was superior to a synthetic ligament. There is not much out, not much more than this, but we're all using the graft. And I think in 2019, there is a kind of a golden standard towards a graft for the chronic, and I think everyone is using it. But the literature doesn't support it clearly. What is chronic? We're all talking about, yeah, this is a chronic dislocation, so we need to do an augmentation with a graft, allograft, autograft, whatever, but what is chronic? When do we need a graft? The data is so weak and is unclear where the border is between acute and chronic. From 3 weeks post-trauma, this is what probably most of the people say when you ask them, and what we know from one study from Rolf is that potentially the early surgery will lead to better clinical outcomes. This is the study by Rolf. There is one study out trying to determine the term acute and chronic, and Flint and his co-workers just asked colleagues and said, what do you think? What is chronic? And they asked for ACL, they asked for AC joint, and so on. And for the AC joint, most authors said, well, acute is within 3 weeks, range 1 to 3. And then they asked them, okay, fine. What is chronic? And they said, well, chronic is easy. It's all from 6 weeks on. Now we have a problem. What's going on between 3 and 6 weeks? Is it subacute? Are we using a graft? Are we not using a graft? So this remains unclear. There is no data out. Let's switch on to the surgical techniques. This was done for years and years. Mr. Weaver and Dunn, they showed that the transfer of this CA ligament can lead to a stable AC joint. But what Tauber, my colleague in Munich, showed is that if you have a free semitendinosus graft, which is wrapped around it, it's biomechanically much stronger and the clinical outcomes are better. Also, this has been shown from Mazzoca and his group. He does this, what he says, anatomic reconstruction with a free semitendinosus graft and 2 screws fixed to the clavicle. Big drill holes, though, 6 millimeters twice with an interference screw. Another surgical technique, Mark Tauber again proposed this triple bundle technique, where you wrap it around the coracoid and then over the AC joint and back. And he compared it to the Graft rope, which was on the market. I think it's not on the market anymore because in some studies it had 80% failures. So hopefully nobody is using this anymore. It's not on the market. Different arthroscopically assisted technique with or without cerclage are in use right now. And this is exactly what you can do. You can do the same as in an acute setting, but then you add, however you want to do this, wrap around the coracoid or bring it through this drill hole, a gracilis or a semitendinosus graft. There is one case I want to show you. This is also, you have seen this guy had an operation before, and you can see how unstable it is vertically, and also you can't see it very nicely horizontally. The view from the subcoracoid space, and it starts the same. He had a hook plate, so no drill holes before. The drill is done, then you get out your passing wire. You drill in your implant. I use 2 fiber tapes. And you can position your dog bone, and you can see through this 4 millimeter drill hole, in this case, the graft is already in place. And it goes over the clavicle in front, and is knotted together there. This is underneath the acromion. And now you can see that you can use the same graft underneath the acromion as well and bring it in here so that you have this kind of a triangle fixation even for the chronic situation with a graft. Also, this is to read in arthroscopy if you want to look this up again. Another technique, because I showed you, these might have drill holes already, these guys. So there was a drill hole already. I took out the implant he had before, but now I don't want to risk it and go ahead and drill again. For sure, I'm not going to come out right where the first drill was, and I don't want to put any more drill holes in here. So this is what happens. You go down with a grasper, medial and lateral. You put some sutures in here through the anterolateral portal. You get your shuttle sutures out, and then you pull from the medial side, pull a little bit more until you have the sutures. Both sides are stitched. And then you come again from the lateral side, put it up, and you have wrapped it around the coracoid. I use as a bracing material 2 fiber tapes, and you can see the fiber tapes, and over the fiber tapes you have the graft. You can see it here that it's knotted together, coming in front and posterior to the clavicle. You knot it together, and if you want to do an AC cerclage with the same tendon, it's possible. Then it's better to use the semitendinosus graft because it's longer, and you have to have a small strand here, a larger one here, and this can go over the AC joint for AC stabilization as well. What are the outcomes? What can we tell the patients? What can we expect? Again, the data is weak that we have on chronic. The chronic cases are not well elaborated. This is from an insurance company. They had 154 retrospectively analyzed patients in 4 groups: a Weber done, a graft CC loop, a graft through the tunnel, as I showed you, and a graft plus a cortical button fixation device. Revision rate, around 10%. No significant difference between the groups. Radiological failures were less in the CC button plus graft group. This is all we can say from the biggest group we have in literature. Take-home message for AC joints. The trend goes towards a single tunnel. So less tunnels, smaller diameters, not to risk a coracoid or a clavicle fracture. Second important step, address the horizontal stability. I think this will be very important to improve our results from now in the future, that we can stand here in 10 years and say we're even better because now we're horizontally stable as well. Chronic, it seems like there is a consensus somewhere around this 3 weeks. We're just working on this with the ESA shoulder section and looking up if we can find a real consensus and what the data is like. Tendon augmentation for chronic cases seem to be the golden standard, and you should use it. Be careful with the drill holes and the fracture risks. Thank you.